The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Sharon Giordano from MD Anderson Cancer Center in Houston, Texas, lead author on Abemaciclib with endocrine therapy in the treatment of high-risk early breast cancer, ASCO Optimal Adjuvant Chemotherapy and Targeted Therapy Guideline Rapid Recommendation Update. Thank you for being here, Dr. Giordano.
Oh, thank you so much for having me.
Great. First, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed. The full conflict of interest information for this guideline panel is available online with the publication of the guideline in the Journal of Clinical Oncology. Dr. Giordano, do you have any relevant disclosures that are directly related to this topic?
No, I have no relevant disclosures.
Okay, then getting into the content here, what prompted this rapid update to the selection of optimal adjuvant chemotherapy and targeted therapy for early breast cancer ASCO guideline update, which was last published in October 2020?
So this rapid update was in response to the publication of an updated analysis from the monarchE study, which led to the FDA approval of adjuvant abemaciclib. So the monarchE trial was an open-label, randomized phase 3 study that evaluated the addition of 2 years of abemaciclib to standard adjuvant endocrine therapy among patients with high-risk, hormone receptor-positive, HER2-negative breast cancer. And this study reported initially at a median follow-up of 19 months that the addition of adjuvant abemaciclib improved invasive disease-free survival compared with endocrine therapy alone, with a hazard ratio of 0.71. With additional follow-up with a median of 27 months, the benefit was maintained with a statistically significant hazard ratio of 0.70 favoring the use of abemaciclib. This translated to an absolute improvement in 3-year invasive disease-free survival of about 5%. The overall survival data were later reported in a letter to the editor. These data remain immature, but at this point do not show an overall survival benefit in either the study intent to treat population or the population consistent with the FDA indication. So in summary, those were really the new data that led us to update our guideline.
Understood. I appreciate that background information. So then, based off this new data from the monarchE trial, what are the updated recommendations from the guideline panel?
So the guideline panel had 2 updates to our previous recommendations, and both of them around adjuvant abemaciclib. Our first recommendation reflects the FDA indication for adjuvant abemaciclib. So this recommendation just matches the label, which is that 2 years of abemaciclib, which is dosed at 150 milligrams twice a day, plus endocrine therapy, may be offered to patients with hormone receptor positive, HER2 negative, lymph node positive, early breast cancer with a high risk of recurrence and a Ki-67 score of greater than or equal to 20% as determined by an FDA-approved test. So this recommendation just completely matches the FDA-approved indication for the drug. However, the data that were available for the panel to review to make this recommendation was from the published manuscript from the monarchE trial. So these data showed a significant benefit in the intent to treat study population. So the panel felt that the use of abemaciclib was also reasonable in this population of patients that matched the clinical trial population. So based on this reasoning, the panel also recommended that on the basis of the published analyses, abemaciclib for 2 years plus endocrine therapy for 5 or more years may be offered to the broader intent to treat population of patients with resected, hormone receptor positive, HER2 negative, lymph node positive, early breast cancer at high risk of recurrence. High risk, as defined by the monarchE trial, was either 4 or more positive axillary lymph nodes, or for patients with 1 to 3 positive axillary lymph nodes, they had to also have either a grade 3 tumor, a tumor at least 5 centimeters in size, or a Ki-67 of greater than or equal to 20%. So those were the 2 new recommendations from the guideline panel around adjuvant abemaciclib.
Thanks for detailing those 2 new recommendations. So what should clinicians know as they implement these recommendations?
Well, I think it's important for clinicians to recognize that the panel recommendation was a may rather than a should. And we felt that it was important to allow for adjuvant abemaciclib in high-risk patients, but also felt that the risk-benefit profile needed to be considered in individual patients when making this decision. So, to summarize the data, the adjuvant abemaciclib was shown to be associated with a better invasive disease-free survival, but not overall survival at this point, and that these benefits really need to be weighed against the potential harms, including treatment toxicity. So the patients who were treated with abemaciclib did have higher rates of toxicity. The incidence of grade 3 adverse events was higher among patients on abemaciclib, and it's 50% versus 16% for the patients just on endocrine therapy. And of note, the most frequent adverse events of any grade for patients receiving abemaciclib included diarrhea at 84%, fatigue at 41%, and neutropenia at 46%. So, these were not surprising from the data we have in the metastatic setting, but still could significantly impact a patient's quality of life. And so just as we would for any treatment decisions, really we need to consider toxicity when making treatment recommendations, as well as the potential benefit.
Definitely. And then you've just mentioned both benefits and risks and adverse events, but in your opinion, how will these guideline recommendations impact patients?
I think overall, these new recommendations provide an additional option for patients who have, hormone receptor positive, HER2 negative breast cancer, and who are at high risk of recurrence. So these patients now have an option of additional therapy to help reduce their risk of recurrence. And I think overall, that's really good news for our patients.
Absolutely. That's definitely good news. So then what are the outstanding questions regarding optimal adjuvant chemotherapy and targeted therapy for patients with early stage breast cancer?
Yeah, there's great questions. There still are a lot of unanswered questions around the use of adjuvant CDK4/6 inhibitors. One important question that I don't really know that anybody knows the answer to is why this study showed a benefit using adjuvant abemaciclib, but the other clinical trials of the other adjuvant CDK inhibitors have not shown a benefit. So I think these results are somewhat surprising given that each of the CDK4/6 inhibitors had benefits in the metastatic setting. I suppose there could be a difference in the drug itself. Maybe it's the dosing because abemaciclib is a continuously dosed drug. But overall, the answer to this question isn't clear. I think that for patients treated with adjuvant abemaciclib, it'll also be important to see longer-term outcome data to ensure that the benefit in invasive disease-free survival persists, and to see whether this treatment ultimately impacts overall survival. Because ultimately, we certainly hope that we can identify treatments that are going to meaningfully improve outcomes for patients with early-stage breast cancer without having undue toxicity.
Great. Yeah, we'll look forward to those longer-term outcome data and finding out those answers to those questions that you mentioned. So I want to thank you so much for your work on this rapid recommendation update, and thank you for taking the time to speak with me today, Dr. Giordano.
No, it was my pleasure. Thank you so much.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/breast-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.